Welcome and thank you for joining us for today's Healthy Living Lecture event on Peripheral Artery Disease, or PAD, What You Need to Know, hosted by Henry Ford's Senior Healthy Living Program. My name is Diana Heinley and I will be your moderator for today's lecture. I'm a coordinator in the Vascular Surgery Clinic at Henry Ford West Bloomfield. This afternoon you will hear from Dr. Tamer Boules, a vascular surgeon with Henry Ford Health. Dr. Boules will provide an overview of the role your arteries play in pumping blood around your body and when this process is interrupted and the possible health problems that may happen, including peripheral artery disease known as PAD. Dr. Boules will also discuss how you can reduce the risk factors that increase your chances of having PAD. Following Dr. Boules' presentation, we'll have a question and answer session. So if you have a question during or after Dr. Boules' presentation, please type your question into the chat box and avoid sharing any personal medical information. Also, to ensure a smoother experience for all, please turn off your cameras and note that your microphones have been muted. The lecture is being recorded and will be available to listen to again on the Healthy Living Lecture Series webpage at henryford.com/healthylivinglectures. And now I'm happy to introduce Dr. Tamer Boules.
Good afternoon, everybody. It's a pleasure to be here, and thank you, Diana, for the introduction. I look forward to providing you all with some great information about peripheral arterial disease, what you need to know. Hopefully this will provide some great information, alleviate some concerns you might have, and give you some good resources as to where to go with your concerns if you have any. Today we're going to be talking about peripheral arterial disease, of course. We're going to be talking about what PAD is. PAD is the abbreviation for peripheral arterial disease. What are the causes of peripheral arterial disease? Who is at risk? What symptoms you might expect to look out for, and maybe what symptoms aren't related to PAD. The testing that we obtain when appropriate to diagnose PAD, and then some introduction to the treatment options for PAD. So what is peripheral arterial disease? Well, to understand that, you have to have some understanding of how the circulatory system in your body works. It's divided into arteries and veins. The arteries are the main blood vessels that carry blood rich in oxygen and nutrients from your heart to the rest of your body. And those are the ones that are most in question when we're talking about atherosclerosis and peripheral arterial disease. Peripheral arterial disease results when the arteries in your legs become gradually blocked by plaque or hardening of the arteries through atherosclerosis, and results in symptoms from not enough oxygen or blood being received to the muscles and nerves in the lower legs. So on this diagram, you can see that there's a cartoon of the heart right here in the middle, and all these arteries provide blood flow to the legs through various named vessels, the iliac arteries and the femoral arteries and so on. But there are also important branches that go to the brain, including the carotid artery and the stomach and intestines and kidneys that are on the way down through the aorta. PAD is very common. And it's rising in prevalence with at least 21 million people affected to date, and a higher number over the coming years of patients that will come to seek attention for their peripheral arterial disease. Well, what are the causes of peripheral arterial disease? Well, normal arteries are smooth, unobstructed channels or pipes that can become blocked over years through a gradual process called atherosclerosis, which literally means hardening of the arteries. As you age and as you accumulate some other risk factors that we will discuss, excuse me one second, plaque can build up in the walls of those vessels. And you can see in this diagram on the right side that a very common place for it to develop is in the legs. And that is why symptoms are very commonly beginning in the legs. This is another sort of microscopic view or cartoon view of what a plaque looks like on the inside of these small arteries, where it's rich and filled with various things like cholesterol crystals and calcium, which actually hardens it, and a number of other cells that actually create a lot of inflammation in the wall of the arteries and eventually scar tissue that leads to the narrowing of those arteries. As more plaque builds up, the arteries narrow and stiffen, as I mentioned, and eventually the blood flow is reduced significantly to your legs and can result in some of the symptoms that we'll talk about. Fortunately, your body has some alternative mechanisms to try to battle that, including the development of some side streets or collateral pathways, we call them, that try to get around the blockage. But they're not always as good as the original blood flow that you had when the arteries are normal, and they're not always enough to provide the oxygen to your muscles and nerves in your legs. But what's also important to recognize about peripheral arterial disease is that the plaque not only affects the arteries in the legs, but can also initially silently affect the arteries in other places. That same plaque can develop in the coronary arteries, and at least 2/3 of people that have peripheral arterial disease in their legs might also have some blockages or plaque developing in their coronary arteries to various degrees. About 1/4 of patients that have peripheral arterial disease might also have blockages that can develop in the carotid artery, which is another artery that supplies blood flow to the brain. And when it is blocked significantly, it can result in the development of strokes. So it's important to recognize that the atherosclerosis that hardens your arteries might be doing so in places even outside of your legs. And all of those things are important, especially when considering ways to prevent atherosclerosis from worsening over time. So who is at risk for peripheral arterial disease? Well, I did mention that advancing age is one risk factor, but that's not the only one. And there are other things that might even lead to the development of symptoms of peripheral arterial disease at a younger age or middle age. Smoking is one of the main risk factors for peripheral arterial disease. And stopping smoking is one of the greatest interventions you can do to help reduce the rate at which peripheral arterial disease progresses. But there are other factors as well, including diabetes, high blood pressure, excess weight or obesity, and high cholesterol. And all of those things are modifiable or treatable with some good preventive care and sometimes medication. Of course, something else to consider is genetics. And some of my patients report that they have other family members, especially younger family members, even in their 40s, that had signs and symptoms of atherosclerosis, including heart attacks at a young age or problems with blood clots in the arteries or veins at a very young age. So family history is also important. Well, what are the symptoms specifically of peripheral arterial disease in the legs? Actually, early on, there are no symptoms until the amount of blockage begins to become severe enough to limit your ability to perform some activities. So the more active you are, the more likely you are to identify or come across those symptoms of peripheral arterial disease, while if you're pretty sedentary and you don't walk around very much, it can accumulate in your arteries even silently. One of the earliest symptoms is one called intermittent claudication, and that specifically refers to some form of discomfort or pain or heaviness that you note in your legs when you walk. That gets better when you rest. And that makes sense because when you walk, that's when your muscles need the most blood flow to do the tasks that they need to perform. And if you're not able to walk as quickly as you want or even walk as far as you want without developing specifically that tired feeling in your calves and less commonly in your thighs or buttock region, then that might be a sign that you have peripheral arterial disease. But not everybody reports it as a pain, and as I mentioned, sometimes it can be just a feeling of tightness or heaviness, or cramping or weakness in the legs. And it occurs more as you walk faster, walk uphill, climb stairs. Interestingly, it doesn't occur as much when you're riding a bike because you're not really bearing the weight of your legs very much when you're sitting on a bike. So it's really when you're up and around walking that people notice the symptoms the most. But one of the key things is that it goes away when you stop and rest and take a break. The next more severe stages of peripheral arterial disease that start to get us into the concerning symptoms that we'll talk about are pain in the feet, specifically rest pain, which means pain that develops when you're not walking in your foot. And it's not a simple muscle cramp at night. It's not a pain in your foot that you get when you walk, interestingly, but it has more to do with a burning ache in the front of your foot that develops when the nerves just aren't getting enough blood flow to even do the things that they need to do when you're just resting. And it's especially common at night because at night is when everybody's blood pressure and heart rate are a little bit lower. And if your blood pressure gets low enough that your nerves aren't quite getting even the blood flow they were getting throughout the day, they'll let you know by firing off signals to your brain that tell you, wake up, get your blood pressure higher, help me out here. And rest pain is one of those signs that really should get you to see a physician right away. Burning in the front of the foot, especially at night. It's sometimes challenging to tell if that's from peripheral arterial disease or not, because there are other things that can cause burning in your feet. And we can talk about that a little bit in the chat at some point, but it certainly deserves the attention of a physician to evaluate you. And now to the third level of severity of peripheral arterial disease. In very severe cases, and this should prompt immediate attention by your healthcare provider, you can get painful sores on the feet or actually gangrene of toes, which really just means dead tissue that develops. Once the blood flow is so severely compromised that even small cuts or small bumps break down to form areas of ulcers or openings in the skin, or even when the blood flow to a toe gets very severely reduced, as you can see here in this picture, those are signs that the peripheral arterial disease has gotten to the most severe stage and certainly limb-threatening stage. So even before any of those things develop, are there tests that are important in evaluating patients for peripheral arterial disease? Absolutely. And the simplest test is a good physical examination by your healthcare provider, whether it's your internist or your podiatrist or your cardiologist or a nurse practitioner that you see in the office. A good pulse examination, looking at the pulses that you can feel on the top of the foot, on the inside of the ankle, behind the knees, and even in the creases of your groin is very important to assess the blood flow and can be done very simply and non-invasively. And beyond that, your provider might be able to see openings or sores on parts of the feet that are difficult to examine yourself. And so a good foot exam, especially in our diabetic patients, is important to be performed in all patients when looking for peripheral arterial disease. What tests beyond physical examination are appropriate for patients with peripheral arterial disease? Well, it's important to share with you that the initial tests are very non-invasive tests that can be done in the office. So if your doctor suspects you might have peripheral arterial disease based on symptoms that you report or based on an abnormal absence of a pulse in one foot or the other, a test called an ankle brachial index can be performed, which is a fancy term that describes comparing the blood pressure in your legs to your arms. The blood pressure in your legs should be about the same or a whiff more than the blood pressure in your arms. And it's when that blood pressure starts to get lower and that ratio gets below 1.0 or 0.9 in some places, that's when we start to suspect the presence of some peripheral arterial disease. And that should trigger some other, testing and questions that your provider may be asking you. Might also lead to some blood tests to be checked to look for other risks for peripheral arterial disease, like high cholesterol. But this test is very simple and straightforward and essentially painless, like getting your blood pressure checked, but in all four extremities. Depending on the results of that test or how severe your symptoms are, there are other tests that may be important, especially when you're planning some treatments for peripheral arterial disease. Some of those tests get more detailed pictures of the arteries. They include things like ultrasounds that can also be done in the office, just like an ABI can. And then there are maybe some other more specialized tests, more commonly some CT scans, and in some places MRIs that can be done at your local hospital or imaging facility, again, usually as an outpatient, to get a much more detailed roadmap of the circulation and arteries. So you can see here, this is an ultrasound that's getting a roadmap of an artery that's in the groin that goes down to the leg called the common femoral artery. This is an MRI right next to it that gets a roadmap of all the legs from the groin, all the arteries from the groin down to the feet. Here is a CAT scan right next to the MRI, and all these little white speckles are that calcium that I had mentioned to you that builds up in hardened arteries. Finally, this picture here shows an angiogram, which is actually a specialized test that we perform that we'll talk about a little bit more when you're planning to treat blockages. As you can see, a blockage has developed in this artery in the thigh, and that can be treated in various ways when appropriate. So, but not everybody gets these tests, and sometimes none of these tests are needed, and only a good surveillance and preventative program are important over time as your peripheral arterial disease is, as we say, surveyed for any progression to those limb-threatening stages. So how is peripheral arterial disease treated? Well, as I mentioned, most people with peripheral arterial disease don't need surgery or procedures. And most people who have peripheral arterial disease identified on testing based on symptoms or screening really should be encouraged to pursue lifestyle changes to reduce the risks of progression of peripheral arterial disease. Those lifestyle changes, again, most importantly, include smoking cessation, and that couldn't be emphasized enough. Smoking, especially when it's performed with other risk factors around, like diabetes and high blood pressure and high cholesterol, it very much accelerates the development of those more limb-threatening signs of peripheral arterial disease. And exercise or a regular walking program is important because the distinction that we have in evaluating peripheral arterial disease is that some of those patients that just get tired legs or aching in their legs when they walk, those are not dangerous signs. There are no limb-threatening problems associated with that annoying achy feeling that I'd mentioned earlier called claudication. And sometimes those symptoms can improve with a walking program that involves, at least a 30-minute exercise program, or walking until your leg aches, and knowing that there's no danger in having your leg muscles ache after you walk a period of time, and only improvements that can develop as you push it with each individual walking session. So I usually encourage a walking program 3 times a week until it aches, and try to really encourage patients to push through that calf or thigh or buttock ache if they know that that's from peripheral arterial disease, in hopes that training the muscle will improve their walking distance without any procedures. There are other medications that we also prescribe for patients with peripheral arterial disease. Aspirin, as it stands, reduces your risks of having your peripheral arterial disease progress to a limb-threatening level. And it also helps reduce your risks of atherosclerosis progressing to other threatening levels in your coronary heart arteries or even in your carotid arteries that go to your brain. So aspirin is very important. Similarly, cholesterol medications such as the statins are very helpful in slowing the progression of peripheral arterial disease and reducing the risks of those other, as we call them altogether, cardiovascular events in the brain, the heart, and the legs when peripheral arterial disease progresses. So statins are very important if available to you. Controlling other risk factors like high blood pressure and diabetes, very important as well. And I won't get into those too much, but as many of you know, there are medications available that really are doing a wonderful job of trying to control those risk factors for not only the sake of your heart, but for your arteries as well. There are medications that might actually help you walk a little longer distance. There's one in particular that's noted on this slide right here called Celostazol. The brand name is Pletal. For some people, that helps to improve their walking distance or reduce the intensity of their symptoms, and we use it in some patients with a supervised exercise regimen. And really only for those most limb-threatening cases do we use any procedures such as angioplasty and stenting or surgery. And again, the limb-threatening states of peripheral arterial disease are not very common, but they're those last two things I mentioned, the rest pain in the foot, at night especially, and any tissue loss, gangrene or sores that don't heal. And in those more severe cases, there are some treatment options that start to get into procedures because medications are not enough to treat those more limb-threatening stages of peripheral arterial disease. And that's where a lot of the latest technology has really helped us provide more options to patients with less risk. We use minimally invasive procedures such as balloon angioplasty and stenting to help improve the blood flow. And what are those procedures? Well, they involve, usually as an outpatient, patients come to a procedural area where there's special x-ray machines, as you can see here in this picture, and under frequently a very local anesthetic with just some light sedation. An IV can be placed, as you see here, into one of the arteries, whether it's at the wrist or in the groin crease. It's an access point for us to get our balloons to be able to cross blockages in the arteries under x-ray guidance and place a stent in some cases to open up the artery and keep it open as a scaffolding to increase the blood flow into the leg and help improve those symptoms or heal those sores or reduce the risks of losing a limb. And, you know, again, the recovery time from this is pretty short. It's really an outpatient procedure where you're really only resting for, you know, about an hour to two after the procedure, and then you return to near normal activities relatively quickly. And that's really been a great thing for our patients who really benefit from not being in the hospital for days and days or, you know, succumbing to any of the risks of having more invasive procedures. You know, in vascular surgery, we've embraced these minimally invasive procedures, and they're really now used to treat probably 75 to 80% of patients that have peripheral arterial disease when they need treatment for those more advanced stages. And this is a good example of somebody who had a blockage in their iliac artery between their belly button and their groin. The whole right leg circulation was very reduced because of a blockage, and with balloons and stents, that blockage was able to be opened up, and this patient had, you know, immediate improvement in their walking distance, but also resolved the significant pain in the front of their foot that they had at night which was a sign that things were getting limb-threatening. Some patients are candidates for balloon angioplasty or stenting because their blockages are too severe or too long or just in not the right places for stents and balloons to last. And so there are patients that we still offer some open surgical options to. This shows an example of where we open up an artery that's right in the groin, that's blocked significantly and limiting blood flow to a leg, and removing that plaque completely and reconstructing the artery, usually with a little rooftop called a patch that helps keep that artery nice and robust and large enough to avoid getting blocked again. I did this operation, in fact, this morning on a gentleman that had severe symptoms of claudication and couldn't work, and I'm confident that his symptoms will improve, and he should be able to go home tomorrow from this kind of a procedure. There are sometimes more extensive surgeries that are required for patients that, again, have very complex, longer blockages where stents are ineffective or unsuccessful. And we still offer these surgeries. And yes, you're in the hospital for several days after the surgery. And sometimes there are some higher risks that go along with this because they require more extensive anesthetics and people have to recover from the incisions, but they are necessary when you're trying to save somebody's leg that doesn't have any other options. So these diagrams show some of those procedures, bypasses, using either artificial veins, grafts, or sometimes using your own vein. We can borrow veins for bypasses. So in summary, PAD is very common. It can be initially silent and in some not so common cases becomes limb threatening, but it's important to be able to recognize those symptoms at their various stages. And peripheral arterial disease can be diagnosed by your doctor or your primary care provider with simple office-based tests. We talked about the ABI test, which in fact is being offered at a lot of screening centers, even lifeline screenings and other things that are available to you more broadly. Most of the time, peripheral arterial disease can be treated with lifestyle changes and medications to help reduce progression for now. There aren't any treatments yet that we've shown to consistently reverse peripheral arterial disease, but science is advancing at a rapid pace, so who knows, within our lifetimes that may be happening. And finally, minimally invasive treatments are really the main form of therapy for peripheral arterial disease, reserving bigger open surgeries for patients that have more complex blockages. So with that, I'll turn it back over to Diana, and we'll enter the question and answer session. I just wanted to thank Henry Ford for the opportunity to present in this Healthy Living lecture series. And thank you all for taking the time to listen and participate. Diana?
Well, thank you, Dr. Boules. We do have a question in the chat here. It says, I have an upcoming annual wellness visit with my PCP soon. What can he do to help me discover any PAD issues?
Well, that's a great question. And it references some of the things that we went over, but worth going over again, which is encouraging your primary care physician to check your pulses. That means making sure that socks and shoes come off. Pulses are felt in those locations. A good foot examination is done to look for any open sores or any hidden signs of peripheral arterial disease. And then beyond that, it also means looking out for those risk factors, making sure that if your blood pressure is abnormal or elevated, that it's treated with the appropriate means that your primary care provider is equipped to treat you with, getting screened for diabetes when that's appropriate, and having your cholesterol checked. And many of these things are also driven by your risk factors and family history as well. So, and primary care providers are excellent at identifying those risk factors, and we work with a lot of them, and our lines of communication are open with them. We're happy to see if there are any concerns regarding peripheral arterial disease.
Okay, thank you. We have another question. Should we avoid calcium-rich foods or calcium supplements?
That's a great question. And actually, there is no connection between calcium that you have in your diet and calcium that's deposited into the artery walls from the gradual process of peripheral arterial disease. Calcium is metabolized in your body in a completely different way, and we certainly do not encourage restricting intake of calcium, nutritional sources of calcium at all, because it does not influence whether or not the quality of the plaque or the nature of peripheral arterial disease. So it's not something that you should be concerned about.
Okay, and we have another question. Do varicose veins have any relationship to PAD?
Great question. So they do not have any direct relationship to peripheral arterial disease. The veins are actually working on sort of the other side of the circuit, if you will. The arteries bring oxygen and nutrients to the organs and the extremities, and the veins, after those nutrients and oxygen have been delivered, the veins drain the blood away from the organ or from the legs and arms and other parts of the body. So they're not really related. So varicose veins are not limb-threatening and are independent of peripheral arterial disease. But they can cause other symptoms, certainly not dangerous ones.
All right, and we have another question coming in. If I am diagnosed with PAD and end up having a procedure, what does my recovery time look like?
That's a great question, and that depends on what kind of procedure you are having. For most of the minimally invasive procedures, balloon angioplasty, stents, things that do not involve any incisions, your recovery time is very short. Patients that have these procedures are flat or sitting up and in bed after a procedure for about an hour or two, and then they're encouraged to walk around and sent right home. And personally, I allow patients to resume almost all activities by the next day. There are certain really vigorous activities or, folks that perform very extensive exercise where I might have them ease back into it over a few days. But those minimally invasive procedures, the results are immediate and the recovery is rapid. So not a lot of downtime. Folks go back to work the next day after this, depending on what kinds of jobs they have, of course, but most people can go back to work quite quickly, and there's really minimal downtime. Now, if you have a bypass or some open surgical procedure, the recovery is a bit longer, and that again depends on the extent of the surgery. Sometimes people require 2 or 3 weeks to kind of get over surgical discomfort or swelling, but most people, even after those surgeries, still go home within 2 to 5 days of the procedure, sometimes sooner. But they generally require a hospital stay if you're having those open surgeries, which are sometimes necessary.
Okay. Another question is, I wear compression stockings. Will that help me prevent PAD?
Great question. So compression stockings are used in general to treat swelling, and sometimes swelling is a symptom of a vein problem rather than an artery problem. So wearing compression stockings will not prevent peripheral arterial disease, but it's a reminder to the audience out there that if you have peripheral arterial disease and it is at a moderate to advanced stage, wearing compression stockings can worsen the symptoms if the stockings are too tight. And so you have to make sure that if they are prescription-based stockings, higher pressure stockings for more severe swelling, that your blood flow coming down can handle the amount of compression. And that's usually evaluated again with an ABI test. If your ABI is, more than 70%, more than 0.7, most people can handle wearing stockings without a problem. If it's less than that, sometimes your symptoms in your lower legs can be worsened if the skin is sensitive to that compression when it's not getting the normal amount of blood flow to begin with.
Okay, and then we have another question. Who can evaluate me for PAD? Is my podiatrist or foot doctor able to evaluate this?
Yes, so there are several different ways to get evaluated for peripheral arterial disease. Your podiatrist can certainly screen you for that with an excellent foot exam, and podiatrists are also trained to do pulse exams. Some of them actually have ABI machines in their office and can do some of that screening right off the bat when you see them regularly, every 6 months or a year, whatever the frequency is. So podiatrists have frequently been the first people to diagnose peripheral arterial disease. But other healthcare providers can do the same. Your internist, your family practitioner, whoever is providing you that primary care, part of that primary care is evaluating for peripheral arterial disease with a pulse exam and those risk factors that we mentioned to be screened for: diabetes, high blood pressure, and high cholesterol, to name a few.
Okay, great. We've got some comments coming in saying thank you for all the great information. We've got another question. After treatment for PAD, am I cured, or is this a lifelong thing that I'll need to manage?
Another great question. There isn't really a cure for PAD. It is a lifelong process, and probably most of us get some element of PAD or atherosclerosis at some time during life. There are few people that go their whole life without a drop of plaque in their arteries. If you really went looking at folks and screening their blood vessels very carefully. So it is something where once you're diagnosed with it, it requires lifelong surveillance. Now, that doesn't mean that you can't have an immediate impact on its progression, slowing or halting it with all those, wonderful ways to intervene, even without procedures, controlling those risk factors. Smoking cessation is critical. Getting on statins, even if your cholesterol is normal, statins have been shown to help reduce the risks of peripheral arterial disease for those cardiovascular events that I mentioned: heart attack, stroke, and leg problems. All of those different ways to attack the problem can slow its progression dramatically. And especially for patients that have genetic predisposition, where maybe family members in prior generations had circulatory problems at a young age, current medications and preventive therapies have even delayed the onset of peripheral arterial disease beyond to where you would expect it if you had other family members that had it in their 40s or 50s at a very young age. So it's something that you can live with, and it's not something that takes over your life if you can control those risk factors now.
Someone who's been a long time smoker, is it too late? Is the damage already done?
It's never too late. And although there may be some element of the damage that's permanent, there are some immediate benefits of stopping smoking on your blood vessels that people experience. Smokers that have even that first stage of peripheral arterial disease, where they just get a heavy leg when they walk, claudication, as I mentioned that term, when they stop smoking, their claudication improves to a great degree, because I think it's been shown that some of the byproducts of smoking have an immediate ongoing toxic effects on the muscles and arteries that improves immediately when you stop smoking. Does that mean that the blockages that have been formed over years of smoking go away? No, but it does mean that the toxic effects of smoking are ongoing with every puff of a cigarette you take. So it does make a difference immediately, and it's never too late. So I would encourage anybody who's thought about stopping smoking, don't quit quitting. Find every way possible to stop, so you can add years onto your life later, let alone quality of life as well, to keep your legs on you, avoid heart attacks and strokes.
And we had someone that logged in just a little bit late, and it was asking if you could please repeat what claudication is.
Sure. Claudication is a medical term that describes that ache in your leg, heaviness, aching, discomfort, pain. Some people don't really even call it a pain, but it's a funny feeling that you get in your leg, a heaviness frequently when you walk a distance. That's a sign that your muscles aren't getting enough blood flow because of a blockage that's present in one of the arteries. And classically, when people report it consistently, it goes away when you stop walking. When you rest and your muscles don't need that extra blood flow, those symptoms go away. So that intermittent nature of it is why it's called intermittent claudication. It occurs when you walk and it goes away when you rest. And that brings me to another point, which is that there are different other medical problems that can cause similar symptoms. Some patients that have back problems, some vein problems. There are different other kinds of heaviness and symptoms in the leg that can occur with different precipitating factors, different triggers that may sound pretty similar. So if there's ever any question and you think, oh, that's just my back, or oh, it's just my veins, or oh, it's just this or that, it's important to get checked out by your provider to make sure that you're not missing that peripheral arterial disease cause of claudication. We see patients every so often that even have had back surgeries for leg pain when they walk, and it's not until after the back surgery has been done and the leg pain doesn't go away that everybody realizes, well, this may have been actually from this blockage that we found later. So there are a lot of overlapping symptoms for leg pain, and if there's any question, get evaluated by your healthcare provider. Make an appointment with a vascular surgeon if you have access to one, or you've already seen one. That's what we're here to do, is to sort out some of those symptoms and help alleviate any concerns you have about whether or not you have peripheral arterial disease.
Okay, thank you. I'm not seeing any more questions. Does anyone have any last minute questions they want to get in the chat here? If not, I think we'll be wrapping this up here.
Wonderful.
Oh, I'm not seeing any other questions coming in just yet. This is probably going to be bringing us to the end of our event. As a reminder, the lecture has been recorded and will be available to watch again or share with friends and family members. In the next couple of weeks, please visit henryford.com/healthylivinglectures to view the presentation. If you have more questions about PAD or would like to schedule an appointment with Dr. Boules at our vascular surgery clinic, please call us at 248-661-7022. And if you're not a member of Henry Ford's Senior Healthy Living Program, please sign up for this free program, which is open to anyone age 55 and older. To sign up, go to henryford.com/healthyliving or call 313-874-5455. The website and the telephone number are also in the chat box. As a member of Healthy Living Program, you will receive the Healthy Living newsletter, which is published 3 times a year, the annual health and wellness calendar, and invitations to the Healthy Living lecture series. And before we conclude the afternoon, I would like to announce the next 2 Healthy Living lecture events. Please mark your calendar for age-related macular degeneration, or AMD, and Living Fully with Vision Loss on Thursday, November 16th at 10:30, and Managing Your Hearing Loss on Wednesday, December 13th at 2 p.m. Watch your email for invitations to these events and visit henryford.com Healthy Living Lectures for more information and to register. And on behalf of Dr. Boules and the Senior Healthy Living Program, thank you for joining us for today's lecture. Have a great week.
Thank you, everyone.